The last thing is there is another medicine on the horizon that has a triple agonist effect with using the gut hormones that are naturally occurring. And it just increases the benefits of what we're seeing today in the medicines that we have today. So it's in stage 3 testing, I guess, right now in the trials. So we should see that, and then we'll have to talk again.
And it's going to, and one of their touting points is it's going to be a little easier on the gut too, right?
Yes.
Yeah.
Yes.
Welcome to Fated to Fabulous, the podcast for women who know that midlife is not the end. It's the beginning of something bold. I'm Kim Lovely, and I'm here with Vicki Kirby. We're here to talk to you about health, hormones, confidence, and joy. Midlife isn't about fading away. It's about stepping into your power and shining brighter than ever. Let's get into it. Hey, ladies. Welcome to Fated to Fabulous.
Super happy to have you here. Today we are talking midlife, medicine, and metabolism, the GLP-1 conversation in menopause. Woohoo. So I'm going to start off with my yuck and yum for menopause this week.
Love it.
My yuck is my patient who had been struggling for about 5 years, asking for help. I gave her some help, put her on some hormones. She went back to her provider, and the provider said, "Why are you on that? Treating menopause is a fad." That's the yuck. I'm going to give you a yum, a big yum.
That hurts.
Yeah, big yum.
Okay.
That the FDA is removing the black box warning from estrogen products.
Thank
Not
you
all
to the
it
ladies
is.
that have been fighting for all of us, right? Yes.
So, I mean, this isn't particularly good news in regards to vaginal estrogen, which, let's be honest, is completely safe. And these women would go home with that prescription and end up opening their package insert and reading that the cream was going to give them dementia and blood clots and heart attacks and all these things, and they would throw it in the trash. So we are saving women. We're saving their sexuality. We're keeping them out of nursing homes with UTIs and sepsis. So hooray, that's a yum. But I have another yum. Okay, couple. So one, I just became licensed to practice in Maine, so we can help more ladies. And what that means is that I need some help here in New Hampshire. And the biggest yum is sitting next to me. This is Caroline Toussaint. She's a nurse practitioner in New Hampshire, and she is a dynamic human. And when we met, she had reached out to me and said, "Hey, I'm really interested in this type of medicine." And we met, and literally down to the fact that we both have a neurotic doodle at home. We had the same bumper sticker on our car. We've shared patients through the years who are really excited that we're joining together. So I am thrilled. And she's adding something to our practice, which has been a missing piece. In addition to doing menopause care, she is also going to be tackling GLP-1s in the office. So we are so...
Thank you.
Seriously, I'm so excited.
Yeah.
Well, I can't even tell you. When I sent that email and in the subject line, it just said, "Need help?" ? Out of the blue, I just sent it one day. I had been to the New Hampshire Nurse Practitioner Association conference. And were you at that one too, Kim?
No, I was not. Just move
closer?
a little closer. We want to hear your beautiful voice.
Great.
All the things you have to say.
Okay. Well, anyway, I heard Victoria speak, and it was the only lecture of that conference that I actually took notes at, because I'm like, oh my God, I have so many patients like this. And in family practice, you just don't get this educational piece, and you don't have the time to
Isn't
look
she
it
the
up half the time.
smartest?
I know.
Right? It scares me how smart she is.
Not only smart, but really gets you excited about this. So this GLP-1 stuff is very exciting to me, because I remember when it came out, and I had a few patients that had uncontrolled diabetes, imagine that, and they did not want to go on insulin. And so they wanted to try, I think the one at the time that was out first was Trulicity.
Yeah.
Although, if we think about it, Victoza was out, liraglutide was out years before that. So
It wasn't used a lot, though, right?
No, because it wasn't as effective.
Yeah.
And it was used, I think, off-label for weight loss.
Obesity,
But it wasn't very potent for diabetes, and it was an injectable. Yeah. And at the time, people didn't want to do injectable because they equated that to insulin. and nobody liked insulin.
No.
So people started using Trulicity, and then very quickly it went from there to Ozempic.
Yeah.
And crazy.
Now everybody likes the needles.
Yeah, I know.
Give me the needles.
Isn't that the funniest thing?
I know.
When I first had patients in the office and I prescribed it, they would come in, see my triage nurse, Beth, shout out Beth. She would teach them what it looks like, the pen, how to inject it, how to clean the site, things to look for. And so all of a sudden I had this little clinic within a clinic of people coming in needing help with education regarding administration of the med. And so it went from there. It's just so exciting. We're at such a turning point right now, and there's so many things coming, and there's so many indications now. So I'm so happy to be part of this.
And we need to be on the forefront. I mean, Vicki and I have always felt very strongly about we want to be the best at what we do.
Yep.
We do. We want to be the practice that people speak so highly of at doing the best care for women.
With integrity.
With integrity.
Yes.
And the GLP-1 medication, like the two of us have sort of been on whiplash. Like, it's great, it's not great. Oh my gosh, the data. Like, right? So it's been really, really challenging. But knowing that it is a tool for our population and being able to have an expert in the practice thing.
I think for me, so for me, within my practice, so you got to remember I started doing small kind of wellness medicine. And then I was like, I need to learn everything there is to know about menopause, and this is what I need to be doing, right? And so I didn't have room in my little office of one to do the GLPs. And I was also worried that if I kind of ripped that Band-Aid off, I was going to have like every woman in Bedford who wanted to lose 3 pounds. Do you know what I mean? Coming in, and it just wasn't something, I kind of, to be able to add that with integrity is amazing. Question. So I want to hear more about you though.
Okay.
So you tell us about you, backtracking.
Oh gosh. I fought being a nurse for a long time. My mom was a nurse and I fought it. I said, nope, I'm going to go to med school. That didn't pan out. I wasn't that type of person. And so I went home, worked for my dad, and put myself through nursing school after I finished college. And it was what I was meant to do. And I didn't realize it. Like my roommate from college, she would tell me that I always had this little box of things, tinctures and Band-Aids and stuff. And I was always helping everybody if they got sick, if they got hurt.
Dormitory nurse.
Yes, yes. And I see that my daughter is now doing that, which is really exciting. But so that's kind of where it started. And then I was a nurse in the late 90s for years. I decided to enroll in the family nurse practitioner program, and then I realized I was pregnant. So then that got sidetracked for 4 years. And then I started a little late, but I became a family nurse practitioner in 2014. And it was what I was meant to do. I love being with families, with the whole group, knowing what's going on. You know, I think as nurses, we don't look at it as the problem. What do we need to fix? We go, okay, how's your family? What's your dog doing? And what are you struggling with? And it all paints a huge picture together. So I've been doing that since 2014. Most recently, I actually left family practice and worked in a adolescent outpatient acute behavioral health program for kids who are a step down from inpatient or were just really struggling in school and other ways. And that was just a fantastic, I think it was a little less than a year. It was a fantastic time for me to become self-aware of what I really wanted to do, what my passions were, and some introspection and some self-growth. And I wanted to take that education that I learned in such a short amount of time. I learned so much about mental health. And as you know, we all have mental health issues, and we all have patients that are struggling with mental health in some way. So I can add that to it as well. But at the end of the day, I just wanted to take care of women, because the family practice piece, it was great, but I ended up getting a lot of patients that were midlife women and mental health patients and just so struggling. And at the time, I didn't have my toolbox, and now I do. So I'm so excited. I wish I could backpedal and go back to those ladies and say, you know what? I know what you need now, you know?
Yeah, I do think that all the time. I do think like part of why I think we're probably so passionate is because we know. We can think in your brain like,
Yeah, I know.
Yes, I gave you an antidepressant. I told you to go to therapy. But you probably just needed a patch. But now we know.
Yeah.
When you know better, you do better.
Yep. And I think that's the beautiful part of the practice that we have. We're healthcare providers, but we're also passionate about the education, constantly learning what's new. What can we share with our clients? What can we backtrack on? Realize that, oh my gosh, we were wrong on this, guys. Now we need to change.
Yeah. Can you review a little bit? Because I think people are so confused about the different GLPs. Just kind of go through some basics, if you would, like the Ozempic versus Wegovy. Yeah.
I mentioned earlier liraglutide, which was the generic for Victoza. That was the first one that was out a long time ago. And then semaglutide was developed, which is Ozempic. And initially the FDA was approved. It was approved for type 2 diabetes. And then they found that there was a magnificent side effect, which was weight loss. And that was just one of the first things that they found as a great side effect, or I don't know if you'd even look at it as a side effect. Benefit.
Another benefit.
I think it's a great benefit. And so they came out with Mounjaro, which I'll go over the difference between tirzepatide, which is Mounjaro, and Ozempic. But Mounjaro was for type 2 diabetes. So both of these companies developed a similar medication that was FDA approved for weight loss. So on Ozempic side, you have Ozempic and Wegovy, Wegovy is the one for weight loss. And then you have Mounjaro, and then Zepbound is the GLP dual agonist for weight loss. So that's really exciting because it wasn't initially, when people wanted it for weight loss, it wasn't covered by insurance. And so it was $1 million. And that's, we'll talk about compounding, but that's where compounding began for this particular medication. But the difference is that the semaglutide or Ozempic, it has like a 15% weight loss benefit max, I would say, at their max dose. And Mounjaro can go up to like 23, 25% because it has two naturally occurring peptides, which are hormones that are in the gut. They call these the nutrition stimulated hormones that only react when there's food in the gut. Yeah. And they are released by the small intestine. So they're there, but now you've got two in tirzepatide, and so it just is more effective. It's what they think is a more potent or stronger medicine, although Ozempic has great results as well.
That's great.
Awesome sauce.
You mentioned compounded.
Yes.
Talk about that a little bit, if you would. What are your thoughts?
Well, okay. So I've met some people who own compounding pharmacies near us, and they're lovely people. And in fact, I think my neurotic doodle would probably be dead or probably deaf, because he had that Pseudomonas type of ear infection that was only cured with a compounded antibiotic.
Oh, wow.
Interesting.
Yeah. So, and
they're great. Compounding pharmacies are
great. Yes. And I think in the terms of the GLP-1, they came out, they were more readily available because it was impossible to get this medication with or without insurance. And so compounding began, and it has its place, definitely. I would say if you're going to compound the medicine or get it from a compounding pharmacy, you need to do your work. You need to make sure that it has some sort of regulation, that the pharmacy isn't an overseas pharmacy because their regulations are very different, and that what you're getting is not contaminated. You want to look at, there is data on these compounding pharmacies, on their contamination rates and their purity rates of these medicines to make sure you're paying for what they call clean medication. So there is a place for it, and you want to also make sure, this is the biggest red flag, there needs to be a provider prescription for it. And if there isn't, then what kind of medication are you really receiving? And that's a big red flag. So I think that
in other words, somebody with the license to actually prescribe medication needs to be the one that's actually prescribing it to you versus someone who doesn't have a license to do so.
Online with no prescription. So
scary.
And then there's other components to it, like some of them are not injectable, some of them are sublingual and oral, and the data isn't there to support the efficacy of those medicines.
Know that just by going through the GI tract, those P and GLP-1, they're lost up to 85%, right? Because our natural endogenous that we secrete from the gut ourselves, only 15% gets to the systemic system. So if you're doing them that way, how much of that medicine is actually getting to where it needs to go?
I mean, minimal amount.
Right?
Yeah.
And I think what'll be exciting for our practice, having access to prescription, FDA approved, finding the right candidates. And, this has been the missing piece in my practice, right? Because I will see these women and they are eating, we've got them down to it, right? Kim has met with them. They are eating that cottage cheese. They've prioritized breakfast, like protein. They're lifting heavy weights and they're optimized on their hormones. But that 25 pounds that happened before they hit us is just not going anywhere. So I think that for that reason, it'll be exciting to see what we can do for those women to get them past the hump of that while they're doing all the other things. And and data does support that, the two in combination, doing hormone therapy and a GLP, you have more
Before we
effective.
end the compounding discussion, one thing that I learned, which I didn't know, is that you can't get the ingredient list. So we have a mutual client who had a major allergic reaction to a compounded formula. And even the person that had prescribed it to her went in search of the ingredient list. And the company that supplied it couldn't even provide the ingredient list. And to me, that was a red flag because we have no idea if the person's actually allergic to the medicine or something that's in the carrier.
Right. That's interesting. They say that in data, you're not supposed to compound a medication if it's FDA available in that form. Right. And so the way they get around that is if it's not available, which was in the case of the GLPs at one time, but also they can say, well, we offer it with the additional so we add some vitamin D in there or something. And that's how they compound a different type of medication. And so you don't know the percentages of these meds that are in there.
And it could be junk of those two things. It could be not even bioavailable vitamin B12 and right D.
Exactly.
Who knows?
Exactly.
So when somebody comes to see you,
which I hope will be soon.
Yes, that's the plan.
I'm already putting people in your schedule,
this
ready
airs,
or not.
Right? Like recording this podcast.
You'll be like, slow down.
In early November.
Yeah.
And
who's a good candidate and who's not? What are kind of things that you'll think about when you meet with somebody?
When we think about the type of person that could benefit, I think it's exactly what you had mentioned. The person that is in midlife that is struggling with menopause and weight gain and metabolic changes and hormone fluctuations, that is a great candidate. There are some contraindications to this medication, and primarily they do say that if somebody has a family history or a personal history of medullary thyroid cancer, they shouldn't take the medicine. But if you do a deep dive into that research, it's really just animal studies that they found it in mice, and they have never been able to convert that data and shown that that has happened with humans. But again, we take that caution. And then there's also people who have had this MEN type 2, which is a multiple endocrine neoplasia type 2, personal or family history, same
that's
thing.
Cancer, right? That's a cancer sort of?
It's an endocrine type. So again, those people that have had that or have a family history, that we really need to have shared decision making on whether that's a good option for them or not. And then there's other things like if you have a personal history of chronic pancreatitis, that's a huge one because if you think about the hormones that the GLPs are kind of activating, they are in the gut. So that's why some of the side effects you see are nausea, vomiting, diarrhea, or constipation initially. So those are the types of patients that generally, I mean, there's other types, but if you think about it now, and this is why it's so exciting, we're going to be in a place where maybe they don't need weight loss, but they have terrible bone health, and they're really concerned about fractures, and they have a high cardiovascular risk. We're seeing that this medication has so many benefits that it is for the ones that are FDA approved for weight loss, but I think we're going to see it for other things as well.
We'll see more indications coming out.
I mean, they already are out, and cardiologists, I have to tell you this again. My roommate from college, I told her I wouldn't say her name, but I saw her recently we went to a Coldplay concert in July, and she's all fancy. She lives in Long Island, works in New York City, and I'm always jealous when she comes up because she always looks so good. And she's on Zepbound, and I said, oh, that makes me nervous. Why are you on Zepbound? And she said her mother, unfortunately, had just died, and they think it was from vascular dementia related to uncontrolled cholesterol over the many, many years. She was on Lipitor for a long time and probably wasn't monitored as closely as she needed to be. And my friend and all of her siblings, there's 5 siblings in the family, are all on Zepbound because they have such a high risk of cardiovascular disease. And she's also in menopause, so she's gained 25 pounds, and it's really helped. She and her family are very thankful that now we have the science behind it, and she won't hopefully have the same outcomes, unfortunately, that her mom did. And so that's just one story of a friend of mine. There's going to be so much of that.
Oh, yeah.
And so I think we're on a super highway right now. We're not on the back roads anymore.
And you know what's really cool too is we're going to be able to address all those potential side effects from the very beginning, right? So, you know, if women have this sniff of a constipation, we're going to nail it. Like we're not going to have women who are having the GI symptoms that are out of control. We're going to be on top of that. And I think just the time frame, right? We're not necessarily looking at a lifetime, unless of course that is beneficial to somebody, but we're looking at more of sort of what can we do in the short term to sort of kickstart metabolism and shift that annoying 20 pounds that's been sitting there. So I love because the people that I have sort of recommended look at a GLP-1 have said, well, what's my future going to look like? What am I going to do? Am I doing this till I die? Like, what's going to happen? And we never really had good answers to that question. But now we know that this may not be a lifetime thing. In fact, we're really hopeful that it's a very short term, which is fantastic.
Yeah, I think we need to have more data. It's been too short of a time. And I think they've done 1 or 2 studies that have shown if you take it for a year with Ozempic, then you really need to take it longer because the weight will come back on. But we have to think in broader terms. If I don't need my high blood pressure medicine anymore, and I don't need my sleep apnea device anymore, and I may not need my Lipitor anymore, but I just need a GLP-1 for the rest of my life, what is the story? What do we? So I think it's really exciting to think about that. And also, when you talk about the side effects like constipation and the GI things, that's why they start it slowly.
Yes.
This 2.5 milligram dose that you do once a week for 4 weeks, and then you can consider ramping it up, is to get your body used to the medication, to kind of jumpstart the metabolism, but not at a high dose where you will experience those symptoms, or you may. Your body is used to it. That's why that slow dose escalation is really important. I know when people get on the bus and they're like, okay, let's go straight to losing weight. They want to jump right to the highest dose, or at least start at 5 milligrams. But that's why it starts slow and low.
Yeah.
Perfect. Interdisciplinary team. Let's talk about that.
So, we are the converts already, but talk to some of the women that might be listening about why it's so important to have an interdisciplinary team like we're going to have. What's the benefit, or why is it imperative?
A few reasons. When you think about taking a GLP and you lose weight, 2/3 of that weight is going to be fat. But 1/3 of that may be muscle mass, and we have to be aware of that. So I think if you prescribe and just give a GLP-1 without adding dietary monitoring and a kind of a platform for resistance training and exercise, then I think you're doing the patient a disservice.
Yes.
The other thing is, if you don't want to be on the medication long term, then you've got to change your lifestyle.
Yes.
And you need to incorporate more protein in your diet. You need to do the resistance and strength training. You need to have good sleep. And all of those things combined will help you to hopefully not need the medication for years and years. There are definitely indications. If you have high-risk cardiovascular disease, as my friend does, then she probably will stay on it forever. But for those people going through menopause and hormone changes, and they're already on a patch, and they want to lose that stubborn weight, and they've tried everything else, then we need to get on the bus and get the medication, get the team with you, and get your village going so you don't have to be on it forever.
I'm a registered dietitian and a life coach, right? So I think even the coaching piece, because people come to us with a lot of old programming and diet mentality and calorie counting and emotional eating and all of that. And so I think during the time of medication, what I have heard from multiple clients is that it quiets down the brain a little bit and it gives us a chance to actually live your life without food noise. And what does that look like? What does that mean? And how do we train your brain to behave that way going forward with or without medication? And, and I think that's the kind of stuff that you can't do by yourself. Like, I think you really need somebody else to help dig into that. Like, why are you in the place that you're in the first place, right? It's obviously the 20-pound gain is, I'll blame it on menopause and hormone shifts, but sometimes women come into it with a history of dieting, under eating, over exercising, and all of that. So to be able to address that, I think is
weeding
really
it out,
important.
right? Too, like weeding it out. Also, like the person
Yeah.
that comes in and is like, I have a grape and a bite of cottage cheese. Oh, here's your GLP-1.
Yeah, no.
Let's
That's
send you
not
into
gonna work.
more of an eating disorder.
No,
Right.
No.
Yes.
Yeah. And I think too, we're going to put our reputation on the line doing this, right? So, like I said, our clients, the resistance training is not going to be optional. Show me the receipt of your gym membership. Tell me exactly what you're doing. Like, there's going to be some accountability,
definitely.
so that we know that they're not going to lose lean body mass for lack of trying to avoid it. If it happens and they're still doing all the things, then we're going to have to deal with that. But we're going to do everything we possibly can to avoid that happening, right? And I think that's hard to do by yourself.
Yeah. The great thing is that we have that data now to, when we first started prescribing them, like, oh yeah, let's bring your A1C down and your blood glucose down, and great. But we didn't, you didn't talk about loss of muscle mass and the need to exercise, the need to eat more protein and more regularly. And not, sit on the couch, take your GLP, and have those M&Ms after dinner, right? Which are delicious. Yeah. And it's true. The food noise. I think it's tied in with emotional eating when you're in changing. Life changes and your hormones change, and you kind of have more emotional eating sometimes. And the other thing is that pleasure center of wanting this food. You're not hungry, but it's a part of livelihood, of having a good life. You want to go out and have a nice dinner with your friends and that kind of thing. And so to be able to still do those things, but be aware of what you're eating, I think there's a huge part. And it definitely goes into the multidiscipline. So I think you're going to need that whole team to be as successful as you can be without losing a lot of muscle mass, and to be able to hopefully wean off the medicines in a short amount of time. Everybody, it's different, though.
Yeah.
If you had to pick 3 things for somebody to consider about jumping in.
So I thought about this question, and 3 things kept changing rapidly.
We'll pick your favorites.
So if they're considering it a GLP-1, let's think about doing it for the right reasons.
Yes.
Number one. So I really think that's where you really dig into why they're here, what are they struggling with, and really listen as to what is it just for weight loss, or is there a whole huge component surrounding that? And then the other thing I always say is patience. So a lot of us in this world don't have any patience. They want to inject a medicine, and tomorrow I should be 20
I'm
pounds
skinny.
lighter. Yeah. This medicine with, like I mentioned before, the slow dose escalation, it does take some time to see that the scale go down and feel better, and you can't be discouraged by that. So that's one thing to know. And also, it may or may not be a life commitment. It depends on many, many things. So those are my top 3 today.
I love it.
It'll probably change.
Well, we'll come back in part 2. So, fine. Do you want to talk about cost?
Yeah, so since I've been prescribing, Eli Lilly came out with a pen-free vial. So before, it used to be so expensive, if you could get it, because even if it was covered by insurance, it had this pen that was self-administered, self-dosing pen. And so you could just use this pen, click it to where you needed to, and inject yourself. And that whole pen piece, that apparatus, was most of the price of the medicine. So Eli Lilly came out with a just selling vials, which is great because you can do a 2.5 milligram dose using the vial, or you can get a 5 milligram and do 2.5 doses with that. So it's more cost effective that way. The price is much cheaper than it used to be, and it's FDA approved. It's through a FDA approved pharmacy with all of the certifications and everything that go behind that. So that's the way I think we're going to do it, because we know what's in that medication. We know there's no contamination and the purity is there. And we also know that we're doing it safely and with integrity to be able to give somebody that.
We are over the moon.
Yeah.
I am too. I keep
So
reading
excited.
research, and it's killing me. If anybody wants more detail about this, I know my friend Amara, years ago, she was my nurse practitioner student. She turned me on to Peter Attia, MD.
Oh, yeah.
ATTIA, MD. And I drank the Kool-Aid. I got the whole subscription, and now I get the secret show notes.
I'm so jealous. I don't get the secret show notes. I need those.
But he has wonderful discussions about GLPs.
Yes, he
In
does.
fact, I think he's had 3 now.
I want to hear his most recent
Yeah.
one.
Yeah,
It looks really
it's
good.
fantastic.
Okay, I gotta start
and
listening.
The last thing is there is another medicine on the horizon that has a triple
Yep.
agonist effect with using the gut hormones that are naturally occurring. And it just increases the benefits of what we're seeing today in the medicines that we have today. So it's in stage 3 testing, I guess, right now in the trials. So we should see that, and then we'll have to talk again.
And it's going to, and one of their touting points is it's going to be a little easier on the gut too, right?
Yes.
Yeah.
Yes.
Yeah. That's very cool. I was at a lecture and it was introduced, in his very beginning stages, and one of the
That's really cool.
is that it'll be a little less rugged on the
It
gut.
begins with
which is
an
great.
R. I don't want to
Yeah.
say it because
Yeah.
I'll just it's a lot of vowels.
Yeah, but it falls into that same tiny
It is. It's like
something like
you
that.
add some regular or whatever.
Yeah.
I don't know.
Just mumble it.
Yeah.
And I don't know what the trade name will be, so I can't speak to
Yeah.
that. But it's just so exciting that there's so much data for our patients and for us to kind of share.
stuff,
So
ladies.
I think we're on the cusp of something exciting.
So exciting.
Yeah.
Happy that you're here. So happy
Likewise.
that you're in my practice.
Likewise.
Welcome,
Thank you.
Carolyn.
If you're in New Hampshire, you know where to go.
Yeah.
Come and see us.
And you know our beautiful wellness cottage. We now have one more beautiful woman in there.
thank you.
It's so great.
So thank you for tuning in today, ladies. Thank you, as always, for sharing with your friends. And come check us out on fatedtofabulous.biz.
And give us comments. Let us know what you
feedback.
think.
What else
feedback
do you
is
want us to
awesome.
talk
Yeah,
about?
feel free to give us questions. We love the questions.
We never shut up. It's fine.
we
We have
never
lots to
shut
say.
Bye,
Thank you.
everybody.
Bye. Thank you.
Thanks for spending time with Vicki and I today on Fated to Fabulous, where midlife is just the beginning of your boldest chapter yet. If you got something out of today's episode, we'd love it if you'd share it with a friend and leave a review. Hit subscribe so you never miss an episode. And if you're looking for more support, inspiration, or sisterhood, come join us at fatedtofabulous.biz, because you were never meant to do midlife alone. Until next time, stay fabulous.